Good evening. My name is Sarah. I will be presenting a case study today for MSN 605, care of the acute and episodic client. Case study is date of service was 9/30/2022. Chief complaint, shortness of breath. HPI is a 66-year-old male who presents for increased shortness of breath that has worsened over the last 24 hours. The patient contacted our office earlier in the day, letting the nurse know that he suspected he pulled a muscle in his right chest wall and was having increased and increased shortness of breath. He was encouraged to go to urgent care or the emergency room, but stated that he would like to book an appointment at our clinic for a time this afternoon. Patient upon arrival was markedly short of breath with significant air hunger upon arrival despite his normal O2 flow of 4 liters via nasal cannula. Very difficult to obtain an HPI for this patient just due to increased work of breathing and his difficulty breathing due to shortness of breath. He was able to state to me that his oxygen saturations yesterday were 94% on 3 to 4 liters, which is his normal. But he thought he had pulled a muscle in his right chest wall the night before and had been having increasing shortness of breath and increasing pain in the right chest with breathing. He denies any pain at the time of arrival or during our exam. He denies any knowledge of fevers over the last 24 hours. He has recently been treated for CT positive community-acquired pneumonia with Rocephin and Levaquin over the last several weeks with IV fluid resuscitation, which he was showing signs of improvement until this episode the night prior. His current problem list includes a prior myocardial infarction, coronary artery disease, hypertension, recurrent pneumonia, COPD, tobacco use, atrial fibrillation, and a prior history of pneumothorax. The patient has allergies to pollen, penicillin, dust, and no known food allergies. Prior surgical history were colonoscopy, laparoscopic cholecystectomy, bronchoscopy, left inguinal hernia repair, stented coronary arteries, right inguinal hernia repair, appendectomy, gastric bypass, and bilateral inguinal hernia repairs. During review of systems, patient did note marked respiratory increased shortness of breath and right thorax pain the night prior. He did not verbalize any pain during our exam, but was very short of breath during our exam. Vital signs on exam were 79/42 for BP, heart rate was 120, respiratory rate 22 to 30, temperature was 97.8, SpO2 was 54% on 4 liters with 0 for pain level. Physical exam, constitutional, acutely ill male, appearing in obvious respiratory distress, marked air hunger noted. Skin was dusky skin color, diaphoretic and clammy. Eyes, pupils were equal, round, reactive to light and accommodation, extraocular movements intact. ENT, normal external ears, ear canals, and really the ear exam was deferred. Neck exam, supple, no lymphadenopathy. Chest exam, respiratory exam was critical. The right lung sounds were diminished with little to no air exchange in the right lung, upper or lower lobes. Left lung sounds were diminished to the bases with moderate air exchange noted to the upper chest. No tactile fremitus noted. Let's see here. Cardiac exam was markedly difficult due to his current respiratory status, but irregular pulses were noted radially. Abdomen was soft and non-tender, no masses, no hepatosplenomegaly, no CVA tenderness. Bowel sounds were present in times 4 quadrants. Musculoskeletal exam was deferred due to respiratory status. Neuropsych exam, patient was alert and oriented. Mentation was intact. Affect varying from lethargic on onset to slightly agitated at times during our exam. So with this patient being acutely ill and in obvious respiratory distress, our assessment was marked acute hypoxia with unknown etiology and marked shortness of breath, air hunger, and acute respiratory distress. Emergent admission to the outpatient to stabilize the patient while EMS was notified due to the oxygen saturations of 54% on 4 liters, and this being a clinical setting. The ER doctor was notified and accepted the patient to the ER at the time of phone call. Patient was placed on oxygen. Continuous cardiac monitor was applied. Labs were obtained. Chest x-ray was obtained and an IV was initiated, and a 1280 kg was initiated. Oxygen saturations on admission were 54% on 3 to 4 liters via nasal cannula. The patient has a marked history of progressive COPD, so he was not given full-blown 15 liters of oxygen, but we did increase his oxygen to 7 liters via non-rebreather mask, which brought his oxygen saturations to 74 to 76%. Continuous cardiac monitoring and EKG showed that the patient was in a new onset atrial fib. He has a history of atrial fibrillation, but has been in sinus rhythm in prior visits. So this was more than likely a compensatory atrial fibrillation, or could have been atrial fibrillation that was preceding this respiratory event, but more than likely the latter. Given the severity of the situation and the urgency, the patient was transferred prior to blood gases being obtained, but we did obtain a D-dimer, CMP, CBC, lactate, and a lactate. And then, as I said, the blood gases will be obtained at the hospital emergency room. A chest x-ray was obtained. COPD with a poor baseline chest x-ray was noted, but on previous visits, but today's chest x-ray was markedly altered, with the right side having more of like a pulmonary bleb or a large locular area in the right lower lung. So a PE was not able to be ruled out. IV access was obtained just prior to EMS services arriving. Report was given to the EMS services and to Dr. Hughes at the emergency department, and the patient's wife was contacted and given an update on the urgency of his medical issues. The patient was awake, alert, and oriented enough to sign consent for transfer to the ambulance, or by ambulance, to the hospital. And he did so. He was alert and oriented and knew the severity of his situation. After the patient was transferred, we did get notification that the patient had a spontaneous right-sided pneumothorax. A chest tube was placed in the emergency department, and the patient was transferred to a tertiary care facility. According to an article from McKnight and Burns, 2022, spontaneous pneumothoraxes can develop from chronic underlying conditions such as COPD, asthma, necrotizing pneumonia, pulmonary fibrosis, to name a few. Patients at increased risk for spontaneous pneumothorax are smokers, those with a history of pneumothorax, and a family history of pneumothorax. Examination findings indicative of pneumothorax are increased respiratory rate, respiratory discomfort, hyperresonance with percussion, decreased intensity of breath sounds, tachycardia, hypotension, respiratory failure, and cyanosis. For this particular patient, this situation met all of the criteria that were labeled in the article that I quoted. The patient is a smoker. He has an underlying history of chronic COPD. He also has pneumonia, or current actively recovering from pneumonia, and he has a history of pneumothorax. So he meets all the criteria for a pneumothorax, but a D-dimer was obtained and was slightly elevated. So a VQ scan was done at the hospital setting when he arrived to the ER to rule out any sort of pulmonary embolism.